This week on the BackTable podcast.
The trick is seeing your needle the whole way. I see a lot of, trainees who will start the needle and advance it, and then they'll look for it. Well, if you don't see it all the way in, it's going to be hard to find later on. So that being said, once you have your needle in the retroperitoneal fat and you can see the kidney, you can see your target, at that point, it's important to go very definitively, because the next time the patient takes a breath, that posterior lower pole calyx, which is hopefully dilated, will move, and then you can't see it. So if you can see it and you can see your needle, then it should be one definitive move through the cortex and into the calyx.
Hello, everyone, and welcome to the BackTable podcast, your source for all things IR and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and BackTable.com. This is Aaron Fritts as your host this week, and I'm very excited to introduce our guest today, Dr. David Field from MedStar Georgetown University Hospital. Welcome, David.
Thanks for having me.
Before we dive into our topic today, just want to say a quick word from our sponsor, RadPad. RadPad was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information. Contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap, and let them know you heard about it on the BackTable podcast. So David and I go way back.
Yes, we do. way back.
Way back. We did residency together at Pennsylvania Hospital in Philadelphia. And, we've been friends, I would say, since day one, wouldn't you say?
Absolutely. That's right. That was, what was that? That was a long time ago.
Yeah. Probably the last time I played golf, too.
Me too. Because then we both had kids.
Right. Yes. Before we both had kids, we had kids 6 months apart from one another.
Yep.
And so very good friends to my wife and I. And David went on to do his fellowship at Georgetown. I went on to do my fellowship, and I'll let you. Yes, and I'll let you introduce. You give us a little bit of background about where you are with your practice, David.
Right. So I have been at Georgetown since 2014. And have sort of grown to love all those sort of urinary involved procedures. So perc nephs, prostate embolization, we do renal cryoablation as well. So I've sort of found that to be where I like to spend most of my time. But of course, we do a very broad scope of things at Georgetown, and including a lot of interventional oncology, which I don't personally do, but we do quite a lot of. So it's a very broad practice, and a lot of UFIs as well. Dr. Spies is, of course, one of the forefathers of the UFI. So we do a lot of those there as well.
Okay. So it's interesting. So you guys kind of have little subspecialties amongst the department.
Yeah, we each of us have our little niche. One of my partners likes to do all the venous work. Some people like to do the uterine artery, Dr. Spies and Dr. Caridi, who just left. And then a couple of one of my partners, Emmett Linsky, does a whole bunch of portal venous hypertension work. So he does more tips in a week, I think, than we did maybe in a whole year when we were fellows. So he's really grown that. He and I were fellows together, so he's really grown that practice a great deal. So, but yeah,
wow.
we each have our own little niche. So.
Yeah, that's impressive. And for any listeners who are interested, we did have Alex Kim on a couple of months back to talk about his interventional oncology practice. And we also had Sahir Sabri come on to talk about endoleak treatments. So also some great episodes. So anyway, let's dive into the topic today. We want to talk about placement of nephrostomy catheters. And just we have a lot of trainee listeners. Can you talk through just the placement of a regular neph tube, the most common indications? And let's just start there with most common indications and sort of where are those referrals coming from?
Sure. I mean, the absolute most common indication is urinary obstruction, of course, whether that's from a stone or from a tumor. It doesn't really make a whole lot of difference for the fact that there is hydronephrosis. So most of these come from either urologists who have tried to place a stent from below and were unsuccessful, or from oncologists whose patients have developed hydronephrosis, or some of them come from from the ER with urology sort of on board as well for obstructing stones. And obviously with a great deal of variety in terms of urgency. In the septic patient with an obstructing urinary stone, then it's an emergency. And with the patient who has a hydronephrosis that has gotten slowly worse because of a obstructing pelvic tumor, it's not quite so urgent. But when it comes down to it, it's basically the same procedure.
So most of those referrals coming from urology and maybe even like the ER, GYN.
Yeah, not a lot from GYN, some from gyn-onc, but mostly urology is probably the most common refer. And it's certainly where we are work pretty good about taking patients in the middle of the night if they have a stone that they try to get passed from below. I mean, I don't think they dump patients on us. So
right. So when you get that referral, is it usually a phone call straight from the urologist, or will they have the ER call you?
It's probably a mix of 50-50. Usually the urology resident will call our resident.
Gotcha. Because they've already seen the patient, worked them up, determined.
They've already seen the patient. They know why or why not. Either they've already tried and they can't get up from below, or they know why they can't, or the patient is so sick that they can't tolerate more general anesthesia.
Sure. Okay. Well, so just before we dive into the more advanced technique, I did want to quickly walk through the placement of just a very straightforward dilated collecting system neph tube. Let us, kind of maybe talk a little bit about, single stick versus double stick technique and what you prefer.
I definitely prefer a single stick, but I think to sum it up, I remember being certainly as a resident a little bit intimidated by a perc neph. I'm not really quite sure why, but when it comes down to it, it's really just a drain. The trick is that the target is often a little smaller than it would be for it's like an abscess drain, for example, and it also is moving. It's a moving target because the patient is breathing, obviously, or hopefully, and that makes and so when the kidney's moving, it can be harder to stick. So we do these really for a dilated system under ultrasound guidance, 99% of the time, and I think it's very important to scan the patient in the room before the patient is prepped. A lot of times, techs will like to get their patient prepped, and then you're left with a window there that is really of their choosing. So I really try to ultrasound the patient ahead of time and have a very good idea of the pathway and a very good idea of where we're going to stick on the skin before proceeding. Certainly looking at prior imaging, and almost all these patients have CTs ahead of time. Even if it's non-com, that's fine. But it's very important to know where the colon is, obviously, how far you're going to have to get into the kidney, what the angle is, where the kidney is related to the where the ribs are, and having that in your head before you even scan the patient is important. So.
Right. And so, we'll walk through, the potential pitfalls and complications a little bit later. But with the sort of pre-prep imaging, are you marking exactly where you think you're going to go in?
Yes.
Before they prep it out?
Before they prep, I will, mark on the skin where I intend to start the needle, and I will mark off where I intend to put the probe so that they know where I need space, because nothing's more annoying than needing to ultrasound where there is a drape, because you can't see through the drape, and you need a pretty big window in the draping. So I will let them know where I'm sticking, where the probe's going to be, and so that it doesn't come back to bite you later.
Okay. And so the patient, so you mark your spot, they prep it, everything's ready, you walk in, put your gloves on, your drape. And so kind of walk through what equipment you're using, what's on your BackTable, and how you get the drain in from there.
Sure. We make sure we use a good high quality ultrasound, obviously, first, like, the diagnostic, ultrasound machine, not one that we'd use for, say, just like easy vascular access. But I like to use the INRAD needles for this. I typically use their 21 gauge INRAD, and the INRAD needle has the scored stylet that has scoring over the last couple centimeters, so that it makes it very, very easy to see under ultrasound. Certainly, if the patient is large, some people just don't image very well. If it can be very easy to lose the tip of a needle in the retroperitoneal fat, and using the INRAD needle is a huge help. So the trick is seeing your needle the whole way. And I'll see a lot of trainees who will start the needle and advance it, and then they'll look for it. Well, if you don't see it all the way in, it's going to be hard to find later on. So that being said, once you have your needle in the retroperitoneal fat and you can see the kidney, you can see your target. At that point, it's important to go very definitively, because the next time the patient takes a breath, that posterior lower pole calyx, which is hopefully dilated, will move, and then you can't see it. So if you can see it and you can see your needle, then it should be one definitive move through the cortex and into the calyx. So, so we always do these from posterior to inferior, or almost always. And then once you can visualize the tip of your needle in the calyx, I will take the stylet out, and if I get urine back, I don't inject at that point. I put the wire in under fluoro, and if the wire goes down what can only be the ureter, I don't inject at that point, because certainly if the patient's infected, you don't want to over-pressurize the system, there's really nowhere else the wire can be going, right? So, and then I usually use an 018 Nitrex wire, or the 018 wire that comes in the AccuStick set, but I think the 018 Nitrex is just a little bit better. And I try to get it down the ureter before I dilate up with the AccuStick. Sometimes it won't go, but at least make sure you have enough stiff wire in the renal pelvis, so you can upsize. So,
and real quick, before you upsize, for our trainees, what's the danger of over-pressurizing? That temptation to inject contrast.
Right. If patient is infected and then you inject over-pressurize the system, you can cause great deal of bacteremia and sepsis, and the patient can start ruggering right in front of your eyes. They can go from bad to worse very, very quickly. So,
which we've probably all seen before.
Yes,
if you've done at least a few neph tubes, you've seen that happen.
That and or with biliary drains as well. Obviously, I think it happens a little more often with biliary drains in my experience. But so
I didn't mean to sidetrack you. Now you're dilating.
Right. So you under fluoro, get the AccuStick set in, keeping the wire very straight, and certainly the AccuStick set that we have, there's a radiopaque marker on it. The tip of the set actually sticks out a little farther. So if you over advance it, it can make the turn, making the turn a little bit difficult. So just got to make sure you get the metal part through the renal cortex before teeing off the first tee off, and then get the final tee off into the renal pelvis. And then at that point, take everything out, and you should get copious urine back. That I will always inject at that time, just enough to prove that the AccuStick set is in the renal pelvis. So, and that you can get a good idea of your course through the renal parenchyma. So,
yeah. Do you guys collect samples of the urine and send that off ever?
Absolutely. Often, I will almost always do it, especially if the patient is obstructed and infected. No, definitely. The sort of the flip side of not overpressurizing the system is if you decompress the system, then it's hard to work in, right? So if you want to leave enough hydro, is that you can get your wire in and get your tube in behind it. So I will either send a sample if it's really, really dilated. I'll send a sample once we get the AccuStick set in, or you can also just send it off the tube after you get the tube in.
True. So, yeah. So real quick, and we'll talk about, a lot of times that urine can be a little bit blood tinged, right? Because of all the manipulation. I guess for the new IR or the trainee, that was one thing that was kind of hard to get used to, how much blood is worrisome,
Yeah, right. It takes a very little bit of blood to make urine look pretty red. So, Kool-Aid is absolutely fine. If it is frank blood, it's a problem. And of course, if it's pulsatile, it's also not the best. But if you get your tube in and it's just a venous bleed, it'll probably tamponade. So and if you've made a one stick with a 21 gauge needle, the chances of really having a significant bleed are pretty low.
Right. All right, well, great, yeah. And so, and then you take your picture, right? You always want that final picture.
You inject the acoustic second and just had to make sure that you are in the renal pelvis. And at that point, then you have to get your wire in. And we just use an Amplatz wire, a short Amplatz. And once you're got, the floppy coiled in the renal pelvis, then it's just a matter of dilating. And then we just put in usually an 8.5 French, a Cook multi-purpose drain.
Do you ever put, if it's like Frank Puss, do you ever upsize?
Yeah, sometimes we'll go to 10, sure. But of course, every time you dilate and you're, take out the dilator, put in the next dilator, you're also going to expose the bloodstream to pus there, right? So that's a little more manipulation, and it just depends. So it's always easy to upsize later,
right?
But I wouldn't really go past 10.2 French.
Gotcha.
Yeah.
Okay, so that's a great walkthrough. Let's take a step back real quick in terms of, and this applies to both basic and more advanced technique that we're going to talk about here in a little bit. Is approaching these patients in turn. You already talked a little bit about pre-procedure imaging, but what labs are essential? Coags, and then what are you doing for antibiotics?
We used to give Cipro, but that's is not the greatest anymore. So we've been giving ceftriaxone, immediately pre-procedurally these days, which has been working well. But yeah, obviously need to know if they're recent coags, and I think the latest SIR guidelines suggest that an IR of 1.8 or lower is fine. So above that, we would correct with FFP or whatever needs to be corrected, and platelets 50 or higher is fine.
What about a patient who's been on like aspirin?
Baby aspirin, don't care, but certainly 325 aspirin or Plavix or any of the platelet inhibitors optimally would be a 5-day hold. But obviously, if the patient is infected, you can't. You can't wait that long. So you have to balance, the emergent nature of the procedure with
how sick they are.
Exactly. So
gotcha. Okay.
I also wanted to say, if you make a stick with your 21 gauge needle and you're not in and you think you're in, but you're not, the tendency is to inject a lot of contrast. I think, I've seen a lot of trainees who will, inject some. It's not a calyx. I certainly did this a lot. You're like, oh, maybe it is. Maybe I'll inject some more. Maybe it'll look like a calyx, or
right.
And it's fine to sort of puff your needle back very gently. But if you inject a lot of contrast, trying to show that you're in and you're really not, it's just going to make things harder for you down the road, because there's invariably a little bit of air and with the contrast, so it's going to make ultrasound very hard. Fluoroscopically, it's going to obscure things. So I think it's important to, if you're not in, just to go back to ultrasound, try it again, and not inject too much contrast into the perinephric space. Yeah,
I think that's really good advice, because I've seen it just look like, a bomb went off. Yeah, especially with the non-distended collected system, which we're about to get to. But where like you said, there's a big stone in there, and you start injecting contrast, and then you have no idea where you're going.
Right, and then later on you can be injected, but you won't be able to see it. So
right. So let's talk a little bit about this is kind of a technique that you've I guess worked on over the last several years in terms of getting good success at getting into a non-distended collected system, because I've myself and I've seen others struggle, and before you know it, you have like 2 hours and like an hour of fluoro time, and you're still not in, and you're like, what do I do? Because you're like, do I keep going, or you've got a whole list of procedures to follow, and you're already behind, and you're like, when do I call it quits? And so so I'm hoping that you can help some of us out there who struggle with that, and to try and prevent that with some technique. And so, first of all, though, tell us some common scenarios where a non-distended collecting system needs a Neph tube.
Right, sure. So the patients that we do the most on are patients who have, staghorn calculi, who are needing percutaneous access for stone removal by urology. But also quite commonly, and probably increasingly commonly, there are patients who need complete urinary diversion. Patients who have had like Fournier's gangrene and or have leakage from a sort of damaged urethra, patients who have a pelvic malignancy and who have a vesicovaginal fistula that just will never heal because they just can keep leaking urine through it. Patients who have had pelvic radiation because of a tumor and have radiation cystitis and have, just continuing hematuria. So all of these patients need urinary diversion, and often we will get asked to do that. And it's really almost never an emergency. It's just, these are kind of, chronic problems that just need to be fixed. So.
Right. So it's usually preoperative or perioperative, having maybe something to do with, or related to tumor, I guess.
Yeah. Or just patients whose quality of life is such that they just have their perineum is continually bathed in urine, and it's just
right.
skin breakdown, or they're just, they have such bad bleeding from their bladder. And some of these patients have bladder tumors, so the urokinase in urine just make them continually bleed, and it's never bleeding enough that they are unstable. But these patients need continual transfusion just to maintain their blood loss. So if you can remove, remove the urine bathing the tumor, then that often will help it stop. So
interesting. Yeah. Okay.
But of course, these patients have completely non-dilated systems, and that makes it very hard to get into.
Right. So let's talk about that. Right. How do you approach these guys?
So the way to get in them more easily is to make them A, easier to see, and B, bigger. So at Georgetown, we have a Philips system that has a guidance software package attached to it called their Expert Guide CT. And we basically can do an on-table Dyna CT, and then the cone beam CT image that is generated allows you to pick a target calyx and the entry point on the skin, and you thereby know that there's nothing in between the skin and the calyx, and it will create the exact fluoroscopic angle under which to stick the system. So once you've selected your target and your skin entry, the C-arm goes to a specific position, and then on the fluoro screen there is a target where you start your needle, and then under fluoro you just advance it straight down along the beam, and then about halfway through the machine will rotate to the other 90-degree angle, and then you can follow your needle to the target. Does that make sense?
Yeah. So, but are you trying to stick right down to the stone? Is that what you're trying to do?
Right. We pick the target. If it's a stone, then it's an easy target, right? But if it's a non-dilated system for urinary diversion, I will give the patient IV contrast, and I usually give them about 90 milliliters. If it's unilateral, if it's bilateral, I will usually give about 75 on one side and then have to give some more on the second side. But if you give the patient the IV contrast with a 10 milligram chaser of Lasix, the system will plump up right under your eyes. So as long as the patient is ready to go, then you can give the IV contrast, give the Lasix, and then you do your Dyna CT, and you will see the calyx light up and plump up because with the Lasix. So you actually have a much better target.
I see. I gotcha. So they're already prepped and draped, and then you give the Lasix. You give the IV contrast.
Yep.
Give the Lasix, and then how long do you wait usually before you do your cone beam CT?
I usually wait about 5 minutes.
5 minutes. Okay.
Yeah. But during that 5 minutes, intermittently fluoro, and if you start to see the calyx appear under fluoro, then you go ahead and do it.
You go. Yeah. And then are you work on a timer? Are you kind of pressed for time after that? Because
not in that instance, because once you've done the Dyna CT, you have your target.
I see.
That you can define your target based on the image you get from that on fluoroscopic CT. And even if the calyx becomes, even if the contrast empties out of the calyx later, you can still use it as a target because you're just asking the computer to define that target for you.
I see. Wait, and if the patient moves, does that matter? Like if there's
Well, yeah, the patient moves. It's a it's a hassle. We will often do these with anesthesia, and sometimes with the patient's prone, so they always like to tube the patient, so they can do apnea, they can do breath holds. It actually makes it
gotcha.
much easier. So we do the breath hold right before the Dyna CT. They're motionless, and then as you move the needle, you also ask the anesthesiologist for apnea, and that makes it much easier.
Okay.
Yeah.
All right. So yeah, so those are great tips for basically, and then are you using ultrasound at all in those cases?
In those cases, often not.
Okay.
Yeah.
It's just pure CT and fluoro.
Yep, exactly. I will often ultrasound ahead of time just to get just more information about where the kidney is related to anything, but no, or to give a specific sort of a general area to be prepped, but often just the fluoroscopic guidance that is provided by that Philips system.
Gotcha.
This is the same. I know that when Dr. Kim was on your the podcast a few weeks ago, he talked about doing angioablation, and this is the same system that he uses for guidance for the ablation probe into the liver.
Sure.
So it's the same system.
Gotcha.
Right.
So yeah, ideal for just basically helping to direct your needle exactly where it needs to go, without any guesswork. Basically, is what it sounds like.
There's no guesswork. You know where you're going to end up. You know where you're going to start, and you know that there's nothing in the way, right?
In the way, right? No colon in the way.
Yeah, exactly. And you can, if you think that there's pleura in the way, you can just bring your skin entry point more inferiorly. The tricky part is just following the dotted line, basically that the software produces under fluoro.
I see.
You grab you still use an INRAD needle just because that's what we use, but we drive it with a hemostat under fluoro, and that's really the only difficult part is staying along the path that the software has determined.
Okay. And so are there any pitfalls to deal with, like, where, you obviously want to keep an eye on your angle, could be aware of like the pathway the tube needs to make, even though it might be the shortest pathway, the angle might not be right. Can you speak to that a little bit?
Right. Well, I think that comes mostly, I think that's mostly important when you're doing access for a urologist who wants to do, stone removal either, the next day or the same day, because they like to come really in a very direct path from the skin to the kidney. Whereas if you're doing something under ultrasound, your tendency is to have a little bit of an inferior to superior angle on your needle. So when you're doing it for a urologist, you want to think about how they want to be looking at the kidney when they do the stone removal, and
right.
and try to come in in a direct as possible path.
Gotcha. That makes sense. And so we already talked a little bit about bleeding, and we talked a little bit about, avoiding crossing the pleura. What happens if you do cross the pleura? Have you had that happen? And what do you do in that case?
I personally have not actually had that happen.
Yeah, that's good. Good.
So I think it's really important to be cognizant of where it is. And if you're below the 10th rib, you should be fine.
Yeah. And then any other complications to worry about?
Other than, bleeding and, sepsis, nothing. These people are not typically infected, right? Because they're non-dilated. So
right.
we really just worry about bleeding.
Right. And I guess ever seen, a situation where there's been injury to, we talked about trying to avoid the colon, but injury to any other organs,
Yeah, I have not seen that personally, but I think that really is one of the main points of safety when you're doing, nephrostomy of any sort, is being very cognizant of where the colon is and where other things are. And under ultrasound, it can be a little bit hard to see a colon that that is potentially decompressed in that area. So
right,
looking at the pre-procedural imaging is very important, and also just being cognizant of what is between the skin and the kidney.
Right. And with that, a lot of times morbidly obese patients, it's almost impossible to use ultrasound, or it's very extremely limited. in those cases, even for the distended kidney, or do you guys find yourselves using Dyna-CT more often?
Occasionally, but it's really mostly for the for the non-dilated.
The non-distended, yeah.
Right. Because, it involves anesthesia and it involves just a little more of a hassle, right? So,
right.
And, a lot of people don't have this capability, right? So,
right.
We should probably talk about how you can do non-dilated systems if you don't have the magic of the
yes.
Of the software that will tell you how to guide your needle, and you basically have to create it yourself. So what I did before we got this system was ultrasound the patient first and plan a path into the kidney. Just under ultrasound, making sure there's nothing in the way, making sure that I'm hitting the right part of the kidney, and then I will mark on the skin where I'm planning to stick, and then I actually put the C-arm in position so that I can stick down that path. So you tilt a little caudad, a little LAO if you're doing a left-sided stick. And then at that point, with everything ready to go, like the 21 gauge needle in hand, that's when I give the contrast and the Lasix. And at that point, you do have a very short or a relatively short window of time during which you're able to stick, because you do it on directly under fluoro, right? So you just intermittent fluoro until you see the calyx appear. It will get a little darker, a little bigger, and then you have to stick definitively. But it's really just the same thing. I will fine tune the path by basically putting like a hemostat at the point I know I'm going to start out on the skin, and then moving the II so that that directly overlies the dilated and newly apparent and opacified calyx. And then I just stick straight down the beam, parallel to the beam, into that calyx. So
I gotcha. Head on, like right down the barrel, basically.
Right, exactly. So you're looking right down the needle. Exactly.
Yeah.
I will always take a still shot as well, because then you get a much better picture of what you're sticking, but then actually stick under fluoro. And then once you think you have made it there, then you have to bring the II to the lateral position, and you can tell whether you are through and through potentially, or you're not quite there yet, but you'll be very close.
Right. Then you have to use your triangulation.
Exactly. You're basically doing what the fancy Philips software does for you.
Yeah.
You can do it yourself. But in that case, it's you do have to move relatively quickly because the contrast will empty out of the collecting system.
Right. Have you ever had to re-inject?
No, but it certainly have not been in when the contrast has gone away. And in that case, you have to, basically you're close, your needle is close, and then you just have to figure out exactly where you are, and then, kind of re-stick and right. Inject a little bit of contrast, again, not injecting too much, to obscure your path, but it's definitely it's definitely more challenging than have the software, do it for you.
Right. Yeah. I mean, obviously, like a lot of people don't have fancy software.
Right. Exactly.
So they got to do it.
Right. Yeah. As long as you have fluoro and you can give the patient the IV contrast. The trick really is the IV contrast to opacify the system, and the Lasix to pump it up. I'll give 10 milligrams usually per side.
Okay. So in terms of the next step, once you get that needle where it needs to go, do you ever inject air?
Yeah, sometimes, especially if there's obscuration by previous attempts, that certainly helps. It also helps if you are not quite sure where you are and it looks like you're not in, but air obviously is non-dependent, whereas contrast is heavier, right? So the patient's prone. So if you inject contrast, it's going to preferentially fill anterior calyces as opposed to posterior calyces. Right. And of course, you want to be in a posterior calyx. So air is certainly good for that.
Okay, gotcha. When you already have contrast in there.
Yeah, when you already have contrast.
Yeah,
it'll give you a little. It's good negative contrast.
Yeah. Once you get access, get your wire in. Now, there have been times where I've tried to, I've stuck down straight down on a stone, for example, right?
Yep.
The stone fills the collecting system and I cannot get, I know I'm in, but I can't get my wire to pass because it can't get around the crunchy stone. So what do you do in those kinds of cases?
Just keep trying and use different wires. Make it as Phil Banovac used to say when I was training with him, he would say, if something doesn't work, don't keep trying it. Try something else, right? So just try a different wire. If you have enough stiff wire to get your AccuStick set in, then you can almost always get it. Glide wire, stiff glide,
right.
Whatever. The 018 Nitrex I think is really good for getting past stones. You can also, if you are able to, once you're in, you can plump up the collecting system by just injecting more saline or contrast or both, right? Dilute contrast. You don't want to obscure your wire, but you can also, if you know that you're in, you can pump it up.
I think I've tried that with saline just so I don't obscure, just in case you're not, all the way in is just because you'll get that resistance, it's kind of that feel similar to doing an arthrogram. It's like you kind of know if you're in or not, if you get that resistance or not. So I would always try a little bit of saline just to create some space around the stone and then try the wire again real quick.
Right. And a couple of times I've actually gotten through a stone with the NRAD needle or whatever you're using. And if you're doing it for a urology access, they don't usually mind that because you're just basically leaving them a pathway to get to the stone. They just need solid access to the bladder, right? So if you go through a stone, it's not they're fine with that. I certainly would say before I do any perc access for like a lithotripsy, I always make sure that I know exactly where the urologist wants to approach the stone. So make sure everybody's on the same page about access point.
That's a very good point. Starting out, I made the mistake of not calling the urologist ahead of time, and I would just put it where I thought they were wanting to go based on experience, and then I got some angry phone calls, and so I just made it, and I don't know, I've talked to IRs about this. Everybody has different opinions on it, but I just made it a policy like any of these stone ones for lithotripsy, I just call the urologist ahead of time, say, hey, I'm looking at the CT right now. Where would you like this access? And usually they really appreciate you asking them.
Absolutely. And you develop relationships with them, and then it's
right.
Everybody's much happier. So
for sure. Because I think I had one or two cases early on in my career, first starting out where I put it in the wrong place and I got thrown under the bus to the patient too. The patient was not happy because the urologist said, hey, the IR doc, put the tube in the wrong place. You got to have this over again, and so that's never good either. So I think that covers it in terms of the procedure itself and kind of, any kind of pearls and pitfalls. Getting access. How about post-op care? Once you got the tube in, you get them cleaned up. What's to follow?
Well, we obviously check them. We follow them while they're in house. Make sure they're not bleeding, that their urine clears over time, that their output is what it should be, and then typically these are permanent tubes, and so they will come for every exchange every 3 months. And a lot of these patients who need diversion because they have urine, they have a radiation cystitis, or they have a pelvic tumor or what have you, and need really permanent diversion, we have been occluding the ureters either at the same time we get the first access or a couple of weeks later. And it's actually once you have access to the collecting system, it's quite straightforward. We've been using this EOS plug that is made by Artventive. And it's actually a vascular plug, but it comes in an 11 millimeter size that works very well for occluding ureters. It's very easy to deploy. We basically get an Amplatz wire down the ureter, and it goes in very nicely through a destination sheath, one of the Terumo destination sheaths, a 6 French sheath. And we get that sheath right down to the sort of 2/3 of the way down the ureter. and deploy this plug through the sheath. It's a 2-step process of deployment, and it has almost like a nitinol spring that opens up, and it's PTFE covered, so they're quite good at occluding ureters. So,
and that's just for the purpose of chronic diversion.
Yeah, patients who have non-healing wounds because they have urinary leakage, or perineal wounds, and who we know are going to need really permanent urinary diversion. Neph tubes will divert most of the flow, right? But especially if the patient is up, there's still path of least resistance flow down the ureters for some of the urine. So if simple diversion is not enough, then ureteral occlusion can sort of finish the job.
Ah, interesting.
Yeah. So typically one plug per side, and it's a 20-minute thing, and you're done.
Before the plugs, were people using coils for that, or?
We were doing this thing where we'd cut the pinky off of a glove and shove it down with an Amplex plug. I mean, it was it didn't work very well. It was very hard to deploy. It took a much bigger sheath, so the EOS plug is much easier. Yeah.
Yeah. Oh yeah. So the last question I had was, what should the expectation be in terms of the timing of clearing of the urine? Like, when should you be worried when it doesn't clear?
Yeah, I would be, if it's not clearing, I would, make sure you're checking the hemoglobin, right? And see if the hemoglobin is falling at all. If it's not falling, then I wouldn't be too worried about it. But if it's, if there's a steady drop, then I'd be worried about a pseudoaneurysm or something like that. Yeah,
you just do a CTA
or sometimes we'll, do if we're really worried, you do the actual renal angiography with the tube. If you got to pull the tube out, right? Kind of like with a
biliary.
Exactly the same kind of thing. But in almost all cases, it clears after a couple days.
Okay.
So.
Well, that was pretty much it. Questions from me. Do you have anything to add for the trainee or any young people out there? That's any other pitfalls to avoid?
I typically will do standard nephrostomies with the 21 gauge needle and then an 018 wire, and then the X to conversion to an 035 wire. I think it would be fine to do a very dilated percneph in a not very fat patient with a 19 gauge INRAD needle, and then go straight to an 035 system, especially if you were really in a rush, right? So you don't necessarily have to go conversion from 018 to 035, but certainly that's the way I train, and probably you as well.
I mean, the obese patient with that dilator. I mean, you got to have a track, a steady track to go over. But in a skinny patient and they're septic, and you just want to get a tube in real quick. Yeah, I agree with you.
Yeah, that's how I do per colis, right? In 19 gauge,
right.
Straight to 035.
All right. Well, that about wraps things up, and we really appreciate having you on, David.
Thanks for having me. Nice to talk.
No,
always.
Definitely good to catch up. For our listeners, again, you can find all prior episodes on iTunes, on Spotify, Stitcher, basically any podcast platform that's out there. We have our podcast on, so it should be pretty easy to find. You can also look on our website, BackTable.com, and we actually have a new web app that has a lot of procedure information, including how to place a nephrostomy tube. So please check that out, and we're adding to it weekly. Thanks again, and everybody have a great day.
All right, thanks.